Sejam bem-vindos ao TechCast, o podcast da Import no Cobrac 2024. Boa tarde a todos. Hoje nós vamos discutir um tema de extrema importância, que seria a artroscopia do compartimento inferior. E nós temos a honra, eu e a Import, de estar com a doutora Reem para estar conversando sobre esse tema que fascina não só os cirurgiões bucomaxilos do Brasil, mas de um mundo todo. Então, muito obrigada pela presença, doutora, aqui conosco.
Pleasure is mine. Thank you so much for having me here. Obrigada.
A artroscopia da ATM é uma técnica que vem ganhando aí muito espaço, né? E como que a doutora acaba diferenciando a artroscopia no compartimento superior com o compartimento inferior?
So, learning about the anatomy of the temporomandibular joint, there is a superior joint space and there's an inferior joint space. And when arthroscopy came out in the early 70s, actually, it was by Onishi in Japan. It was an attempt to be able to mimic and be able to explore the different pathologies in temporomandibular joint with a minimal invasive approach instead of doing an open cut. So in order to do that, you need to tackle each space because each space has its own pathologies and its own disease that you need to treat. Inferior compartment comes where you can tackle the condyle of the temporomandibular joint, any disease there on the fibrocartilage or the bone itself. And along with the inferior compartment, there is part of the disc that you can only expose from the inferior joint space. When you compare it to the superior joint space, you have that superior bony structure with the glenoid and articular eminence of the temporal bone along with the disc itself, and then the whole institution or content of the synovial membrane as well. It comes with a separate entity of diseases as well. So in order to be able to really manage temporomandibular joint disorders, you need to be able to tackle every single part of that joint, superiorly and inferiorly.
Como você acaba diferenciando essas técnicas tanto do compartimento superior para o compartimento inferior?
So again, technique is specific according to the anatomical landmarks, and knowing that the superior joint space is bigger and it has two dimensions of the joint space, anterior and posterior, when compare it to the single joint space in the inferior joint space, and the volume differs because in superior joint space you have a volume of an average of a 2.5 to 3 cc. Versus inferior joint space, you have a volume of only 1 cc or 1.5 cc in the maximum exposure of it. Then the technique is basically the same when it comes to mechanical and theoretical axes. When you want to go into the maximum convexity of the glenoid fossa in the superior in order to be able to get into the joint space in a posterolateral corner of it in the superior joint space, and then you triangulate till the anterior recess of the joint space as well, of the superior part. And inferiorly, you go along with the condyle because you always have to have an anatomical landmark or a sound landmark in order to tackle you into that joint space that might vary between you and me and other people as well. So the difference in the technique would be being larger versus smaller joint space and tackling different anatomical landmark, being the glenoid fossa and the superior joint space in the beginning, in the fossa portal, and in the inferior joint space is going to be the condyle itself and the neck of the condyle.
Essa técnica que ela utiliza para artroscopia do compartimento inferior é uma técnica que pode ser reproduzível por outros profissionais ou aqui no Brasil é muito difícil ou até por conta dos materiais que de repente nós temos?
I was just talking to Professor Antonio Brito about that. The way that I learned TMJ arthroscopy from Joseph P. McCain is to be able to standardize every single technique that I do. So in order to be able to do something, I have to make sure that you can do it and I can teach people to do it in an easy way. So yes, this is part of the trials, like with the kit that we have for inferior joint arthroscopy and the technique that we're about to publish as well. I need to sit there and make sure that I have solid points where I can dictate. If you do that and you follow it with this step and this step, you'll be able to do it. So yes, that's part of the teaching process, and the part of the project that we're doing is to make sure that I have a standardized stepwise technique that I can teach to other professionals.
A TechImport tem um material que é um kit de artroscopia premium. E eu gostaria que você me falasse um pouquinho se com esse kit de artroscopia premium a gente conseguiria estar fazendo essa artroscopia do compartimento inferior. Que é esse kit que nós temos aqui à mesa.
The main purpose of that kit that I see in front of me is for the superior joint space. The difference is going to be in the diameter, but that's okay as well because there's people established. That technique of the inferior joint space was not established by me. It's established way long time ago by Murakami. And I remember that Florenzo Mohi, he just published a paper maybe 2 years ago with a modified technique for the inferior joint arthroscopy where he used the 1.8 millimeter, which is the keyboard kit is going to support as well. So I think that at least for the first level and second level, you'll be able to do it with this kit. Yeah. Knowing the technique.
Sim. Quais são os tipos de indicações mais prevalentes para esse tipo de artroscopia? Processo degenerativo, deslocamento de disco, quais seriam os que você acaba realizando com maior frequência? Inferior.
So basically, again, we're going to go back to the anatomy. So any anatomical part that has disease into it, you'll be able to tackle. Like, for example, most important entity is going to be degenerative joint diseases. So with degenerative joint diseases, whether it's immune-related or osteoarthritis, like secondarily initiated, you'll be able to tackle that fibrocartilage, that condyle. You'll be able to take biopsies. You'll be able to clean the surfaces, do lysis and lavage, flushing that joint space, whatever armamentarium or instruments that you have and whatever pathology that you need to tackle, you'll be able to do it that way. You need to clean surfaces, you do debridement, you can do that. If you have a disease of the synovial membrane, which is part of the lining of the inferior joint space as it is in the superior joint space, you'll be able to tackle those synovial membrane areas, inject medications into it, therapeutic medications into it as well. If there's some pathology or like perforations or stuff in the inferior part of the articular disc, you'll be able to tackle that as well in inferior joint space. So basically, any bathosis that can come into those anatomical parts of that part, you'll be able to tackle.
Aqui no Brasil nós temos como processos conservadores o tratamento com a fisioterapia. Eu gostaria de saber qual seria a sua prática clínica com tratamento conservador ou infiltrativos ou até mesmo a fisioterapia para um pré ou pós-operatório de uma artroscopia.
So when patients comes to me, when they do come to me in my practice and I'm preparing the patient for surgery, we have pre-surgical visit where a patient comes and sit with me. I tell them what they're gonna expect, what holes is it gonna be, what are the potential complications. But most importantly, I tell them that what I'm gonna ask you to do after the surgery is much, much, much more important than the surgery itself. And if you're not gonna be committed, especially in young patients, I say that, if you're not gonna be committed to that rehabilitation and exercises that you're gonna do after the surgery, please do not do the surgery. Rehabilitation physiotherapy is very important. And we started right after the surgery. On the same day of the surgery, we do sets of exercises. We have 3 different levels or stages of physiotherapy exercises that we teach the patient himself or herself to do on the day of the surgery with certain repetitions. Like I say, 20 repetitions 4 times a day, and they have to do it. Whether 2 exercises, 3 different exercises, they have to stick to it. Because rehabilitation of the muscles and ligaments after whatever you did in the surgery is much, much more important than what you did in the surgery. We can do surgery and we can have immediate results, which is going to be fantastic. Patient can open their mouth. They don't feel pain because it's still immediately after the surgery. But if they do not do that reprogramming of the muscles and ligaments, which is really a tiny window that closes within 10 days maximum after the surgery, they don't do it right away in order to stretch and adapt those ligaments and muscles to follow whatever new position or new environment that you created in that surgery, that's going to be harm to your surgery. And at the same time, your surgery is going to be harm to that patient because it's going to heal with fibrosis. So the patient's going to end up closing more or having more pain or having more restrictions in the range of motion. So rehabilitation physiotherapy is very important. seldomly or in certain cases where I indicate a professional physiotherapy and I refer a patient with specific exercises, specific repetition to certain people who are really physiotherapists who are really experienced in temporomandibular joint, because most of the time we refer to orthopedic physiotherapists, and not all of them understand the anatomy of the temporomandibular joint and how different it is from other orthopedic joints. So you need those specialized people. In certain cases, like in degenerative joint disease, advanced ankylosing fibrosis or osteoarthritis, syndromic patients, certain areas that I would need a professional help as well. But physiotherapy is a key from the beginning, because we do not cure TMDs, we manage. So if the patient is able to open their mouth, move it freely, be able to talk, eat normally with no pain, with no restriction range of motion, that would be a success. It doesn't matter what happens inside. It doesn't matter if you removed the pathology altogether or not, because most of the time you're not going to be able to do that. So that's the key.
Nós sabemos da importância aí da fisioterapia, né? Então, realmente não é só a preocupação na indicação cirúrgica, mas sim a importância de um profissional especializado para estar realizando todos esses exercícios, fortalecimentos, diminuição dos processos inflamatórios, o quanto antes para esse paciente ter uma reabilitação ainda melhor. Então agora eu vou abrir as perguntas para a plateia e eu gostaria que vocês participassem aqui junto comigo.
Yeah, the audience, I'm fully exposed. Anna.
Thank you for sharing your knowledge. I'd like to... Tá ouvindo?
Yeah.
Okay, I'd like to know, in your opinion, what's the challenge on the most challenging issue about the instrumentation in inferior joint arthroscopy?
This is a very smart question, because again, the only problem that hinders you from doing a good arthroscopy that gets people, we teach people in courses like in Brazil and in US and all over the world how to do arthroscopy, and then you take a look at what I teach you and how you do it, and it's super easy. You think that you can do it, and then you go back to your home country and you get stuck with reality. Reality is that I know, that I teach, that I've learned that in order to be able to be a good arthroscopist, you need to have good armamentarium, and it's as important as your surgical skill. Because I can teach you how to do stuff, but if you don't have the proper instruments, then you're not going to be able to do anything. You get frustrated. Every time you go inside, you try to do something, you're unable to do it. And then you get frustrated, you think that you're bad or you're not experienced enough, but actually you are good, but you don't have the armamentarium that helps you with it. Because in arthroscopy, we try to mimic all the techniques that we do in open surgery. In open surgery, you use your hand, yes, still with instruments, but you use your hands macroscopically in order to do stuff. Arthroscopically, your eye is this screen. And you have to use your hand with special instrument in order to deliver whatever you want to do, because you're not going to be able to insert your hand. So the question is, if you have the proper instrumentation, design and diameter-wise. And this is the difference. So this is why in inferior joint space, you need to pay attention. If it's smaller space, then it's much better to give you smaller stuff in order to be able to freely move into that joint space, giving it's smaller than the superior joint space. In superior joint space, giving it's 2.5 to 3 cc, then you have to have some diameter of the scope. It can be bigger than the inferior joint space, but still, it has to be smaller than other. Like some people would use the 2.4, 2.7 for temporomandibular joint. You can do it. You can insert that scope inside the joint, but it took almost half of that joint space. Then in order to do stuff, and do operative stuff, you want to cut, you want to put the disc back, you want to take a biopsy, you want to take a look even gently and moving smoothly without harming that joint, you're going to be hindered. It's as if I'm wearing this shirt, which is 2 sizes smaller than me, and I'm insistent on wearing it. So I'm like that, you know, and I'm really hindered, unable to walk. No movement. And in order to do movement, you force yourself. And when you force yourself, you injure that tissue. Then now you're doing harm more than benefit. And this is why armamentarium is a key. That's why we keep developing stuff, being sharp, This is why now the concept comes into being disposable other than reusable, because this takes from the sharpness of your instrument, become blunt. So you exert more force or you cause trauma to that tissue. So this is important. Coming up with specific diameter, specific curvature in order to reach that area without having to go and do harm to that tissue or that track that I reach is a key. So basically, instrumentation is a key for TMJ arthroscopy. You cannot be a good arthroscopist if you don't have the proper toys that we used to call, or tools in your hand.
Thanks for sharing your experience for us. I'd like to know about the medicine. What kind of medicine do you usually use in down stage and upper stage? Is it the same or no?
So it's according to the pathology that you have. So basically, I inject intra-articularly hyaluronic acid. And it's not because of anything other than lubrication acting as a band-aid, blotting those microbleeders that you have. Because there's an important paper by Gary below evidencing that in the evidence of regeneration or half-life of those medication that you inject intra-articular, like flowing in that joint space, whether superior or inferior, it doesn't matter. But for me, I use that because of that immediate effect of it. Even though that I know that the half-life of hyaluronic acid is going to wear off in less than 2 hours, it doesn't matter. So that's intra-articular. Other than that, I use specific medications intrasynovial, which means you go inside the tissue and you inject the medication that that tissue needs. Like, for example, corticosteroids, I can do that. Botox in the pterygoid shadow, where you can tackle the superior lateral pterygoid muscle without having to use EMGs and probes in order to detect it or do it against gravity. That's another medication. There's some initial trials that we try to do a chemical contracture medication by injecting some of the sclerosing medication, but up until now it's still been testing because of the side effects and the long-term effect of it. Those are the kind of medication. In degenerative joint disease, and that's another ongoing research that a lot of people do, you can inject intra-articular PRP, platelet-rich plasma, or PRFs. And again, we don't want to go into that territory of claiming that this is going to regenerate anything. No, for now, we're injecting it in order to compare it to hyaluronic acid in the healing capacity, in the post-operative pain, the effect on the range of motion, post-operative pain, and free of restrictions in the patient quality of life. Later on, it would be injecting stem cells and regenerative therapeutics that we're working on as well, that I think we need to be specific to the areas that you want to regenerate, and you need to make sure in the same time that you halt or tackle the disease reasons. Because if you're not reversing that disease in that area, you might be creating a monster instead of regenerating a normal tissue.
Sabemos que a cirurgia de artroscopia, o paciente às vezes pode passar por 1, 2 ou 3 cirurgias, né, de artroscopia. Eu gostaria de saber se na artroscopia do compartimento inferior é possível realizar também mais de uma, e se na sua prática clínica você acaba realizando mais de uma, e quando que você dá um passo um pouquinho maior para de repente ser uma cirurgia mais invasiva.
Okay, so again, that's going to kick us back into the indication. What kind of procedure that you're doing and what kind of patient or pathology that you're tackling. Because sometimes we're being unfair to the procedure because we're picking the wrong patient or picking the wrong pathology that's not indicated for that certain maneuver. We all agree that for TMJ arthroscopy, we don't need to do more than 20% of the TMD population. You don't need to scope all the patients because you still have conservative management. But then again, it's all about the proper diagnosis of that disease. If you do a proper diagnosis, then you'll be able to know which technique that patient can tackle and that you can benefit that patient. And I was just talking about that, and tomorrow I'm going to talk about that in the keynote speak as well, that you need to widen your horizon. There's a lot of possibilities. You might go into that surgery thinking that the problem is in the disc. But just by putting the patient under general anesthesia, which comes with muscle relaxation of the whole muscles of the body, then you realize that it's not the disc. It's the synovial membrane that had inflammation. It's an anatomical variation in the articular eminence. It's something else. So you need to open your brain. You need to be able to entertain different reasons for that presentation of a patient. Because again, we just manage that patient. We do not cure patient. So this is why we have established, say, that we do not treat X-rays or MRIs. You have to see the patient and couple it with your clinical exam, history taking, and then the radiographic assessment in order to reach what you can do to that patient, whether with surgery or whether with not. For the algorithm or the cascade of arthroscopic management, yes, if you adapt the minimum level 1 arthroscopy to do to the patient, which with evidence base, we have an outcome of 75% of good outcome only by lysis and lavage, flushing of the joint without doing anything else, and make a better look, because with arthroscopy you have the pleasure of being able to see, and you can confirm or modify your diagnosis, pre-operative diagnosis. Then you watch out the patient with rehabilitation, with your post-op routine, and within 3 months, if the patient did not improve or you saw something inside that surgery first level, like in degenerative joint diseases, that you would say that there's so much adhesions that that patient might need a second stage, that patient can benefit from a second surgery. You can repeat arthroscopy or do different levels of arthroscopy in 3 to 6 month increment, and that's a success. That's not bad. We have published a paper with McCain about the algorithm and the cascade. Actually, we adopted that idea that if you follow minimum invasive level 1, then level 2, then level 3 as indicated, then you might have the best outcome of that patient. And you'll have only the minimum amount of patient that might require that advanced surgery, and you might save them the need to do an open surgery. Saying that, some of the patient, we go inside with the scope, we see severe adhesions and degeneration. We tell the patient, if you don't get better by 3 months, then you will need an open surgery, discectomy, and maybe total joints. So it's all about what you see. It's all about what is there in that patient that makes you take that decision. It has nothing to do with arthroscopy itself, because we do not propose arthroscopy as a procedure itself to the patient. No, we couple it with the diagnosis of the patient to help them. And there's a wide variety of the arthroscopic techniques and procedures. It's not only putting a scope in and lysis and lavage. No, you can do so many stuff with the scope according to the need and the indication and the level of skill that you get.
Mais alguma pergunta da plateia?
Yeah, Tayane.
What do you think is the next step or next steps in the surgeon's education in order to better treat TMD patients, including in the better selection of the time to do arthroscopy or not? And what are the challenges that we are facing in the TMD field regarding to it?
Okay, I think there's 2 parts in that question, and thank you for that question. I'm gonna start with the second one. The challenge is that always know what the patient has, and that's gonna always be the question, the problem. Always gonna be the problem is gonna be if you are tackling the correct patient with the correct technique or not. So I'm gonna stick to the answer. We need to go back into diagnosis, and like McCain has taught me, every time that we did arthroscopy together, we would walk in the hallway after the surgery, and I would say, well, we saw this. We never saw this before. This is new. This is blah, blah, blah. And we brainstorm, and he said, well, Reem, the more we see is the less we know. So knowing that, embracing that we're still far from knowing all the different pathologies in temporomandibular joint, working more on exploring and know more answers of the disease itself, learning that, widen your horizon, you'll be able to manage patient better. Because if every time you have a patient, you're just stuck on one theory, like disc displacement, mechanical problem, then you're going to treat most of your patient with only one technique, thinking that that's the help that you gonna do to the patient. And actually you harm the patient and you're harming the technique, because the technique was made for proper indication to help certain people, not all of these. If it's misdiagnosed, then the misindication is gonna cause you miss outcome, and then it's gonna be unfair to the profession. Because people would come and say, well, that arthroscopy, whatever you're doing, is not helping patient. You're saying it's minimally invasive, but we need that other technique. So again, make sure that you have proper indication. I think with all the advent that we're having now with technology, be able to see more, improving on armamentarium instrumentation, optics of the scope and technology of the screens, be able to zoom in microscopically really far and be able to see even the cells. We are able now to see the corpuscles of the RBCs inside the artery moving inside that joint. That's going to give you more answers, and then you'll be able to embrace that, take it in, and always don't be biased. Don't fight for the technique just because you want to fight for the technique. No, listen, because there's going to be something in that criticism that you're having. So I think the challenge would be knowing what to do for which patient. I remember where we're going further. I remember when I spoke to McCain and I told him I need to have my thing. I need to innovate. I need to do something like you did. I need to do something new about arthroscopy. What can I do? He said, you need to have your own thing. What do you like? What are you interested in? And I said, I'm interested in curing TMDs. And in order to do that, I'm talking about regenerative medicine, tissue engineering of temporomandibular joint, whether bone or soft tissue. And then he said, okay, then you do that. And I said, but I need you to teach me how to do that. I know how to do it outside. I need to do it inside. And he said, yes, you can, by knowing the skills, knowing what to tackle, how to reverse the pathology, like I mentioned to you. And he gave me actually the title for my first presentation about that territory. He told me, you know what, Reem, show me the hole and I'll put the ball in. So that's going to be my answer to you, Tayani, is that you need to see the hole, know where you want to put that technique into it, but it needs to really fit into it and to be really in money. So you need to make sure that it's going to benefit the patient.
Muito obrigada.
Obrigada.
Nosso TechCast está chegando ao fim. E Reem, muito, muito, muito obrigada por ter participado conosco.
Thank you. Obrigada.